This is a abbreviated talk of a talk that may be up on YouTube or Facebook, so please refer to those areas as well. I think Tova can probably give you that information, but I'll try to be fast. So I'm Andrea Burke. I'm from University of Washington in Seattle. I'm sorry. So first, I'd like to just go over how we treat craniofacial fibrous dysplasia. And one of the take-home messages that I want to give to you is that this is not something that a single person can take care of. We really need a multidisciplinary team of craniofacial surgeons, which might include oral and maxillofacial surgeons such as myself, plastic surgeons, ENT surgeons, neurosurgeons, and oculoplastic surgeons or ophthalmologic surgeons. And then certainly in conjunction with all of these other folks such as pediatricians, pediatric endocrinologists, all of your dental specialists, audiologists, speech and language pathologists, et cetera. Who we rely very heavily on. And what you may or may not be aware of is that across the country, particularly at children's hospitals, there are craniofacial centers usually that are run by various nursing teams who can also assist with this. So how do craniofacial lesions show up? Well, I would say for what I see, many of these are found incidentally. And incidental just means that it's discovered on an x-ray. More or less, it's usually a dental x-ray that someone is getting, and they sort of say, hey, that looks a little bit weird, take a bigger x-ray, that looks a little strange, and then somehow you end up getting referred. But generally speaking, asymmetry can also be something that people will present with, and this can be in any part of the face, and it's very, very variable. You can see down here below 2 patients that I've seen in the past. I would say generally speaking, those with McCune-Albright, as well as those with untreated or inadequately treated growth hormone excess will sort of have the most severe forms of asymmetry. So as far as symptoms that patients present with, many of these include asymmetry, as I've just said, or growth of a mass, which might not necessarily be symptomatic, but there are some functional changes that can occur, such as vision disturbances or vision loss in the most rare of cases, nasal congestion, hearing loss, epiphora, which is just a fancy word for when your tears overflow, headaches or bone pain, paresthesias, and even more rarely seizures. And this is from a 2011 paper, so clearly needs some update. CT scans are, in the craniofacial region, the gold standard for diagnosis as well as monitoring. There are 3 different planes, which I've sort of put up here in the upper right. But basically you can see on this example, the panel on your left side is showing fibrous dysplasia with the arrows, and then on the right side is one with no involvement, but the maxillary sinus has been obliterated on the affected scan. And panoramic x-rays are one of the x-rays that we will use, with regards to looking at the involvement of teeth. And the thing that's really nice about these sorts of x-rays is that standard-wise, you usually get one of these about every 2 years at your dentist's office. And so it's a nice screening tool that we have at our disposal. But here you can see the upper panel is showing the arrow, which shows some opacification. And again, this is, sort of a screening tool. So we might see something on this and then say, oh, you need to get, a CT of the maxillofacial region, or nowadays many dentists just have cone beam CTs in their office. It's becoming more of a standard of care, and very nice for being able to look and see what's going on. This always comes up as far as bone scans. Technetium bone scans were historically the scans that we would recommend doing. Obviously, they have a lot more radiation exposure than CT scans or sodium fluoride scans, and more of the newer technologies that are coming out. But you can see here, this is a patient's skull. I don't think this doesn't work. But you can just see that black area, it's sort of in the middle, that blob that's lighting up, which shows the extent of the disease. And as far as what CT looks like, what we say is many times we can, diagnose the sort of pathognomonic or the very, very characteristic appearance that you can see on CT is this ground glass appearance. And it consists of obliteration of normal architecture and landmarks. But the important thing is that the cortex, so if I can explain bone to most of you who might not know, I sort of describe it as a sandwich. There's like 2 pieces of crusty bread on either side, and then there's a bunch of like soft stuff in between. And so that crusty bread on the outside can get thinner, but it doesn't actually, perforate through in most cases. I would say some severe cases, which might have something else going on, might. But this is what we're looking at. And so the ways that we are describing a lot of these might include, talking about lucency or an area that's lighter in the middle, that sort of mixed one that you can see halfway down. But sclerotic, which means more dense, can also be used in some descriptions. And what you can see is that there really is no uniform one appearance to this, and the appearance certainly will change over time and as one ages. So here's just an example of that, which is showing here. You can see on the top left, there's a subject who's 5 years old, and then below that, the same subject at 15 years. And I've just put on the right side for your reference what part of the skull we're looking at. So this is sort of the anterior portion of the skull base, and then on the bottom, an example of a patient who's not involved. And so you can see that over time, it's sort of gone from that characteristic ground glass appearance to more, it sort of looks a little bit more like Swiss cheese with some, holes throughout it. And this is something that we'll see very commonly. It doesn't mean that anything is wrong, though. And this is just another example, showing the same area a little bit lower down. Some of the area, you can see the wisdom teeth that are just poking through. But again, age 5 versus age 15, and just the heterogeneity that starts to develop. And then this is just the lower jaw for those of you for reference of what we're looking at. And I think it just came up that we were just talking, I was mentioning to Kelly that one of the good opportunities that you have is that since a lot of kids need to have their wisdom teeth out, is that you don't necessarily have to do a biopsy. Usually the CT is enough, but if your child is undergoing or you are undergoing extraction of your wisdom teeth, sometimes it can provide a fortuitous time to get some tissue to send for testing. So will more lesions develop? We know, that they occur early, as Dr. Collins had mentioned, but they can remain silent until deformity or growth occurs. They can expand or change over time, and it's a lot of this radiographic change that we're looking at, which may prompt us to say, oh, we do think that you need to have a biopsy, or that we might need to engage in treatment. Most dramatic changes are occurring within the second decade of life, and that's usually associated with a lot of, pubertal and hormonal changes. But they can also become associated with rapidly growing lesions, which include aneurysmal bone cysts or, other more destructive lesions, giant cell tumors, et cetera. And so that's why it's important that even if things seem stable, that we're, getting routine screening. And then I think Dr. Shao already mentioned the rare transformation to malignancy. So as far as vision loss, we know that because of the frequent cranial base involvement, there historically was this assumption that you have disease around your optic nerve, and this can inevitably lead to blindness, and therefore we have to do a very invasive, what we call prophylactic optic nerve decompression, and that's where we basically shave the bone around the holes in which the optic nerve is running in order to decompress or provide more space for it to grow. And that's just an example here on the side. I can't use the pointer, but you can see there's like these little dots, and that's where the optic canal is on that patient. However, we do not recommend optic nerve decompression based on the radiographic findings alone, because we know for a fact from previous work done at the NIH that these findings do not necessarily correlate with vision loss. And we know that also fibrous dysplasia is not a progressive condition which results in inevitable blindness. So this is a very important thing, and I would say many older surgeons who might not be within the know are not necessarily aware of this. And here, I just put this down. This is OCT, or optic coherence tomography, which is becoming a newer modality that we're now using in order to risk stratify for optic neuropathy. And I think folks will talk more about that. Putting everything together, hearing loss, again, it's very rare, but I would say getting a tympanogram, which is basically just a test to check for conduction of the middle ear, can be very useful. Ear canal narrowing is pretty common, but that doesn't necessarily lead to hearing loss. And like I said, when it does occur, it's typically mild. One also very rare complication that can occur within the ear canal is something called cholesteatoma, which is basically a fancy word for like a cholesterol growth. And this occurs within the skin behind the eardrum, and it's due to the narrowing that can occur. But the reason why we get excited about it is because it can get bigger, and it can also start to destroy the ossicles, or the bones that help you hear. And so this is the area that we're talking about with those ossicles. And here you can see just an example of the area that we're talking about and what it looks like on the CT scan. And this is an example of some of the narrowing that you might see with the ground glass appearance. And as far as other things that can occur, congestion is probably one of the other well-documented complications. And it's basically occurring because both the nasal passages and the sinuses are affected in fibrous dysplasia with regards to that expansion. And one of the more common complaints that I think we see. So here you can see this photo is just showing us, if you were to have instrumentation of your sinuses. Nowadays we can usually do it pretty minimally invasive, through endoscopic surgery, but to open up the nasal passages and allow for better drainage, of the sinuses into the nasal passage. But interestingly, sinus infections are pretty rare. And then here's just another example showing, again, some of the sinuses. You can see the panel on the left is showing the maxillary sinus. The panel on the right is showing the sinuses that are a little bit farther back behind the nasal cavity, as well as in the skull base, the ethmoid and sphenoid sinuses. And now I'll go on to dental stuff, which is always a pretty hot topic. So this is just to show the types of dentists that are out there. So you have your pediatric dentists, your orthodontists who specialize in braces and skeletal growth, oral and maxillofacial surgeons, prosthodontists. This is sort of a fancier dentist who specializes in full mouth reconstruction and, crown and bridge. Periodontists who specialize in gum disease and in many cases do implants as well, and endodontists who are root canal specialists. And so I always just like to clarify this because I think the terminology can be very confusing for folks. But dental aspects can be overlooked, and so this is one of the things that when I was spending my time at the NIDCR, I was trying very hard to try to characterize. And again, a lot of this is variable presentation because it has to do with maybe where you grew up and whether your water was fluoridated, and genetics plays a huge role, gender plays a role in some cases. So there's lots of different contributing factors. But we know that you can have various dental therapies, which include getting a root canal or getting a tooth extracted, and it's not going to all of a sudden cause the fibrous dysplasia to grow. We have reported this increased rate of cavities, which again, we don't really have a very good explanation for, but suffice to say that having more frequent hygiene visits, so perhaps instead of every 6 months, every 3 to 4 months, application of topical fluoride can help, and getting an electric toothbrush, et cetera. And then we've also reported, I'll talk in a minute about the medication-induced osteonecrosis of the jaw. So here are just some of the anomalies that we have previously reported on. Attrition is basically just wear and tear of the teeth. Retained teeth can be, teeth that, primary teeth or baby teeth that don't, exfoliate as well. Taurodontism, which again, you can sort of see in this photo here, it just means a widened pulp chamber, but we can also see hypomineralization, so decreased enamel, which might be in part, a reason why cavities occur more commonly. Here you can see, again, another example of hypoplasia. You can see the second layer of tooth underneath it, the dentin. And then displacement of teeth, I would say generally, even if this occurs, it's not necessarily a bad thing and can be fixed with orthodontic treatment. And then, oligodontia just means, missing teeth, that you're born with less teeth, and tooth rotation is probably the most common of everybody that we looked at. So tooth extractions may be needed where there are teeth floating or if they're impacted. And again, this could be whether you have fibrous dysplasia in your jaws or not. In some instances, children will require prosthetics, which might help with their growth. And this can improve both function and aesthetics. And so I would say, talk with your dentist as children are growing, because this is something that early intervention can really make a big difference on. Orthodontic therapy, specifically as in younger children who are still growing, can have an effect. And since the majority of patients with jaw fibrous dysplasia have a malocclusion or a disorganized arrangement of how their teeth come together, it's very important to intervene early. And again, this has been seen to be correlated with other endocrinopathies, namely growth hormone excess, although this we haven't really been able to prove. We just know that, anecdotally it's worse. So as far as the crowding, I would say orthodontic treatment is safe to perform. It may take shorter, although there has been a report of it taking longer in fibrous dysplasia bone. And relapse may be more common because teeth tend to return to their initial position. But I've definitely heard from some orthodontists that it's not safe to do. And so this is, data that you can provide to your dentists and let them know that it is okay. Here's an example of just a really severe malocclusion of a patient who did not get treated, and it sort of developed into their middle age with the disease. And you can see the green arrows on that dental X-ray showing the disease on the right side in both the upper and lower jaw. And the whole idea of delaying orthodontics until skeletal maturity, it doesn't really seem to play a role. And as I mentioned, since most orthodontic treatment is being done, in childhood, to help to intervene with growth, it's probably best to do it when kids are younger. So as far as orthognathic surgery, which I think I have a slide on, jaw repositioning and orthodontics is also an option to help to correct asymmetries and malocclusion. That I'll talk in a minute about why it's good to wait till skeletal maturity. Dental implants, this is always a question that we get. It seems that dental osseointegration or the union of an implant to the bone after it gets screwed in may be a little bit slower just because of the quality of the bone, but again, there's no studies that are really supporting this. What we have are just a bunch of case reports that say, yes, there has been successful, placement of dental implants. I think this longest study that I have here is that after 5 years, they were noted to still be functional, but I'll just underscore that, the literature is very limited, and there's an unclear risk of implant failure. I would say speak with providers if this is something you're interested in, because generally there are risks to implant failure, and each case should be taken on an individual basis. And then here again, what we recommend, and this is actually not even a fibrous dysplasia thing, but that implants should be placed after skeletal maturity. But in the case of FD, if you can wait to a quiescent period where the bone is not actively growing, that would be best. Medication-related osteonecrosis of the jaws, which is formally called bisphosphonate-related osteonecrosis of the jaws, is a real complication in fibrous dysplasia, and especially because a lot of our patients are receiving bisphosphonates for bone bone pain and bone growth. And so what we looked at was, when I was at the NIH, we looked at our cohort and found that the prevalence was about 5%. In the general population, it's a lot less than that. It's like 0.4%. So this is actually a little bit more prevalent, but what we know is that there are other conditions such as the periodontal health, your overall oral hygiene, which can play a factor into this. And so there are ways to help to reduce your risk. But generally speaking, it's rare. However, when you do get it, it can be very challenging to treat. So a couple of the different areas where we do surgery, I would say this is really based on a case-by-case basis of the extent of disease, how aggressive the disease is, and its clinical behavior. And the management, depends again on skeletal maturity and other clinical findings, such as endocrinopathies. Lesions, we usually can characterize them as quiescent, which means that they've been stable, they're not growing, maybe they're slow growing or non-aggressive, but certainly aggressive lesions, get us more excited because we think that there might be something else going on and often will require some kind of biopsy. But generally, monitoring with close observation is what we recommend, and this can include things like photographs, doing clinical assessments, doing sensory nerve testing, as well as imaging. As far as indications for surgery, we already talked about that we can do a biopsy if the diagnosis is questionable or if something looks like it's changing on imaging. Obviously, we get excited, like I said, about aggressive growth or atypical behavior, and particularly in the craniofacial region where you have things to worry about like giant cell tumors and aneurysmal bone cysts, it's important. Those are very rare. The different surgical options include contouring, which should be done after growth has stopped ideally because you don't want to contour or smooth down the bone in one area only for it to grow back again. I think the resection and reconstruction can be done if the lesion can be completely removed or if there's concern for an associated disease or a malignancy, but most of the time we're not really performing resections because they tend to be very morbid, very huge surgeries with not such great results. Orthognathic surgery, I already mentioned, is something to help to correct the way your teeth come together as well as different asymmetries. And again, there's really no documented contraindications, and bone healing has been reported to be normal. So regrowth is something that always comes up, and again, I think our understanding remains pretty poor of that, except for in areas of maybe growth hormone excess. So we can't really predict or prevent regrowth, and surgery is not typically indicated for cosmetic purposes, at least initially, I should say, just because, again, when people are younger, it's harder to predict who is going to have regrowth and who is not. But much of this is also, again, like I said, on a case-by-case basis. And this is just some of the outcomes data that we had done previously looking at regrowth and reoperation, and we knew that it was pretty common, but again, we saw less regrowth outcomes with aneurysmal bone cysts and bone biopsies in the groups that we were looking at. Bone resection and reconstruction more or less resulted in less regrowth and fewer operations, but as I said, it has increased morbidity, which just means more complications. And then, again, here's the data showing that most of the regrowth that we had seen was due to those patients who had undiagnosed or untreated growth hormone excess. And so, again, this highlights that importance of a multidisciplinary approach, amongst surgical and medical practitioners. And I will say that if the way that this is discovered is incidentally, and you're seen by perhaps a dental provider, and then you end up getting referred to a surgeon, they're not going to necessarily go back and try to refer you to an endocrinologist or, refer back to your current provider. So it's really, really helpful for you guys to be aware, because then you can then go advocate for yourselves and with this understanding. Here's a paper that I had found sort of more recently where they did look at regrowth. It's out of South Korea, and they were noting that tumor growth rates were significantly lower in patients who were greater than 16 years, which sort of makes sense. post-operative regrowth rates were significantly greater when a shaving operation was performed less than 16 years of age. And so there's some data which sort of leads to why we think we should wait till skeletal maturity. So generally speaking, how do we go about treating? I'll just show some of the considerations. Again, we've talked a lot about whether it's functional versus cosmetic, what the rate of growth is, et cetera. Biopsies, recontouring, resection, and reconstruction. Those are really the options. And there's really no uniformly accepted guidelines, a lot of controversy, as we've talked about, including over orbital nerve decompression. But there's conservative versus radical approaches, and depending on the surgeon you go to and what's best in their hands, it may be different. So some of the advances, though, I just wanted to mention, 3D recontouring has been really useful, and nowadays we can use virtual surgical planning, and we can mirror sort of the normal side onto the abnormal side and perform recontouring. This is an example of where they were doing that. So you can see the screws on the lower right side, which are were placed into the bone a certain depth, and then the bone was shaved to the depth that the surgeons wanted. And that's just, again, using patient-specific cutting guides and things like that, which are really nice nowadays. This is just showing an example of a reconstruction, and you can maybe see on the right side that reconstruction where they took calvarial bone from the skull and fixed it to the area of the zygoma and the orbital floor in order to perform a reconstruction. This is what I'm saying about very morbid, cases. They can be done, but it usually involves a very significant exposure for surgeons to be able to see the area, and then needing to put a lot of hardware on to secure it into place. Orthognathic surgery, as I mentioned, there have been a couple of case reports, but basically they were talking about how it was difficult to tightly affix screws and mini plates in some cases, but overall they did find that the bone grew. I can't believe they got this patient to actually go back in. I guess they were removing the hardware, you can see on the lower left, but you can see that the bone did in fact heal, and so this is very reassuring. And then overall, we were looking at some of the quality of life outcomes as far as craniofacial surgery versus no craniofacial surgery. And I would say that the surgery we found does not significantly impact quality of life in subjects who have received operative treatment compared to those who have not. And this information was taken from our registry, which I encourage you all to join. But this was interesting to us because this was sort of our hypothesis in talking to many of those patients who are affected, that it really doesn't seem to make that much of a difference. But that being said, it is something that we should take on a case-by-case basis, and is a very personal choice for many people. So I think with that, I will stop, and I'm happy to talk to you guys at the breakout sessions. And as I mentioned, with everything being very individualized, please come and ask me about your care and how I might be able to help guide you. So thank you. Who has questions? Yes.
I'd like to refer back to your audiological part. Is it possible to have tinnitus or ringing in the ears?
So the question is, with regards to audiologic, or I guess otologic problems, is it possible to have tinnitus or ringing of the ears? I would say I have not read that it's more common in FD bone, but I would imagine that, yes, it's possible. I mean, it's one of those things that tinnitus could occur anyway. So would would it have happened if the bone wasn't affected? I don't think we'll have an answer to that. No one? Yes. The question is, would veneers fix dental problems? So veneers, for those of you who don't know, are not, you can think of the tooth and it gets prepared, and if you do something that's full coverage, that's called a crown. So maybe many of you have had crowns. But a veneer is really just something where the front of the tooth gets shaved and something gets put on the top of it. It usually will wrap around somewhat. I would say veneers can help in cases of hypomineralization, But you should talk to your dental provider because sometimes, if you tend to grind your teeth, they're not necessarily a good option, for instance. And so maybe a full coverage crown might be better. But yeah, in cases where cosmetics, especially in the front teeth, are an issue, they can help.
Thank you.
Sure. Did you have a question?
He lost his smell.
Mm-hmm.
And
That's a good
you
question.
know,
About that.
and you never hear about the people talking about that. And he just kind of was like, okay, I lost my smell. But do you think there is any opening up or something he should look at?
Yeah, so anosmia, which is the, technical term for it, can happen when you have significant skull-base disease. And I'm trying to, in an instance like this, where you're talking about the area of your brain where our nerves are responsible for sense of smell. If you have very significant disease in this area, it could be possible that it could develop. I don't do skull-based surgery, so I don't know how to answer what percentage of the time, if you were to do surgery on that bone, that it would clear up and you would regain your sense of smell. I know there are some things that you can do, like smell training, which I just learned about. This was pretty interesting because I had a patient who had fractures in this area that we had operated on, and basically went to a therapist to do some smell training, and so and she reported that it helped her a lot. So I would talk to an ENT provider most likely, if that's something you're interested in, or somebody who does skull-based surgery, and they may be able to give you better guidance than I can. But that's I know you can do surgery in that area, but again, I don't know how often it actually helps or works to correct it.
I was just wondering about the efficacy of orthodontic use in bone that has been treated with denosumab or bisphosphonates, and the way that the bone cycling is impacted.
That's a really good question. So the question was in terms of treating with braces in patients who have had treatment with a bisphosphonate or anti-rank ligand or denosumab. I would say we don't know. I don't think anybody's looked at it. If I had to guess, since the bone does change and become more sclerotic or more dense, I would say that it would probably be harder to move teeth. That would be my guess. But I would say it's still not that you shouldn't have it done. I'll have to look in the literature to see. I don't think there have been any reports that I'm aware of doing ortho in patients. Good question. Yes.
So actually, before the orthodontic treatment, we typically screen if patient take the bisphosphonates within the past 5 years. Typically, we don't recommend do the orthodontic treatment because the teeth tend to move slowly. That's much I know.
You said for 5 years?
If I remember correctly, it's about 5 years because that drug.
See, I don't think that makes any sense. Yeah. Oh.
Yeah, no, it's a great question, and like you said, I don't think we have very much data, but probably the most relevant, I think, would come from osteogenesis imperfecta, which is another rare bone disease that's very different from fibrous dysplasia. However, standard of care in that disease is to start bisphosphonates in infancy, right when kids are born, and continue it until they're done growing. So they get 10 years or more of bisphosphonates. And in general, they seem to be safe to have orthodontic care. There's even a study right now at NIH doing Invisalign braces in those
cool.
kids. But I don't think we know if it alters the time to move the teeth, but they do seem to move.
Mm-hmm. Yeah, you should do some research on that. Anybody else have any questions? Okay. Oh, sorry. Go ahead.
You talked about an OCT test.
Yeah.
For looking at the risk of optic nerve decompression. So I never heard of that and was wanting more information.
So I don't know if are any of you guys talking about OCT testing? Or do you want me to talk about it? I feel like I'm not necessarily the expert on it, but basically what we have been recommending doing now is sending folks over to either an ophthalmologist with experience or even in some cases a neuro-ophthalmologist, and these are eye doctor specialists. And OCT has, it's a very minimally invasive test where they can just take, these pictures of the retinal layer and make a determination of those patients who are at risk for developing optic neuropathy, or basically, swelling around the nerve, which we know can be sort of a predecessor to developing, decrease in vision and things like that. And so it's been a very useful tool, like I said, because it's not invasive. Patients, I think we're usually recommending yearly now, to go every year. And so once you've established a baseline, you can then get it rechecked and follow it in that manner. Whereas I would say the older school of thinking was, oh my gosh, you have so much disease around your optic nerve, like we need to go in, and the surgery is very invasive because it requires skull-based surgery basically in order to fix. And that's not to say that folks will never need to have a surgery like that, but like I said, it helps to sort of gauge, maybe when that would become necessary. Does that answer your question? Yeah, okay. Anyone else? Okay.